everybody will attend it now. Most people will watch it later. So let's see if we have people online. Perfect. We are all live now. Thank you. Our apologies. We had some technical issues. That's why we're a couple of minutes late. If you want just to put good evening, everyone, and just say where you're logging from, it would be great to have all of you. I'm just trying to connect the YouTube channel, and I can see it's working all okay. So let's see. There are people. Perfect. So we already have 370 people online. We're expecting the number to go up a bit more. We have 4 talks on imaging update, and we have great speakers. We have Tripti Kulkarni, we have Simon Lowes, we have Gerald Lip, and we have William Tay, all 4 radiologists from the UK. For the discussions, I have the lovely Cem Yilmaz from Turkey, who's one of the surgeons that does lots of imaging also and does run courses on imaging, which is great. Today, we have 4 interpretation channels. So if you want to listen to things in Arabic, go to the Arabic channel. We have the lovely Akram Girgis doing that for us. If you want to listen to things in Italian, then you go to the Italian channel. We have the lovely Michael Sorotos. It's the first time for Michael to do this with us, and welcome to the team, Michael. Then we have the Russian channel. Today we have Katerina on the Russian channel. So if Russian is your second language, they can go there. And if you want to listen to things in Spanish, we have the lovely Ricardo Pardo, who's been with us for a good few years. So it's great to have you all. So what we'll do is we'll do the 4 talks first, and then we'll do the discussion. Each talk is about 15 minutes each. And we start with Tripti Kulkarni, one of the radiologists from Manchester, and Tripti is going to give us an update on mammograms and ultrasound scan. Tripti, the next 15 minutes are all yours.
Thank you. Good afternoon, everyone, and thank you, Yazan, for inviting me to this highly prestigious webinar series. Very excited to be here. Also a little bit anxious because I know that there are a lot of people with lots of different backgrounds from different countries, and it's a little bit difficult to pitch at the right level. So some of you may find it quite basic, and some of you may not. Anyway, let's see how it goes. All right. So my brief was mammogram and ultrasound on this webinar series, which is an imaging update. So I've titled it Breast Radiology for the Breast Surgeon, and I'm Dr. Tripti Kulkarni. I'm from Manchester. I'm the BSBR training lead as well. So I'd like to start with saying, why do we need to perform breast-specific imaging? And I'm not just talking about breast-specific imaging, I'm talking about specific imaging. So for example, on a chest X-ray, you can see the shadows of the breast, but the detail on the breast is seen with the mammogram. The point I'm trying to make is use the right investigation, which is a mammogram for a breast, but it may be an MRI for a different area, or sometimes even for the breast. The commonest breast imaging modality, that's a mammogram. Usually 2-view mammogram and ultrasound are the commonest imaging modalities. A mammogram is performed in our practice at more than 40 years of age. If there is a mass present, then an ultrasound will also be performed. If the patient is less than the age of 40, I would perform only an ultrasound. If, however, the patient has a cancer, then even under the age of 40, I would go ahead with a mammogram. And it's similar criteria for the male breast. A bit of a caveat here in that mammograms are used as surveillance and for screening in younger patients with high-risk family history, etc., even below the age of 40 years. It's an X-ray of the breast performed with the breast compressed between 2 plates. I know this is very basic stuff. The 2 views are mediolateral, oblique, and craniocaudal. And the important thing is that a very low dose of radiation at approximately 0.4 millisievert is involved. And this is something that sometimes we need to be aware of to discuss with our patients who do not want mammograms for this reason. Why would I perform a mammogram? To look for a cancer and any other abnormality which can be seen on both breasts, because it's both breasts that are imaged. Certain cancers are detected early before they become palpable, and therefore screening mammography. Multiple cancers can be detected, and that guides definitive treatment. Decisions can be made on cancer localization, which is essential when cancers are small and are not palpable. It also guides ultrasound. particularly important for large breasts where focused ultrasound can be performed. And of course, it guides intervention, whether via ultrasound or on the mammogram itself. There's an arrow there that points to a little lesion that is sitting there in the upper right breast. A little bit about breast composition. A lot has been spoken about this in these past few years, and how increasing density from a fatty breast to a mixed fatty and glandular to a really dense breast changes how the pickup of abnormality is. And with more dense breasts, there is further imaging that may be needed, for example, a CEM or an MRI. So here you see medial lateral oblique and CC views of both breasts. And in this case, the background pattern is mainly fatty with scattered glandular tissue. The nipples are in profile, so this is a good quality mammogram. You can see the inframammary fold. You can see the pectoralis muscle there, and you can see the difference between the two sides. Here it comes right down to the level of the nipple. So this is quite an adequate film. On this one, not so much. You can see an axillary node that is projected over the pectoral muscle there. The point that I'm making here is that adequacy of a mammogram, adequacy of any imaging is really, really important in order to ensure that we are picking up the right things. Why do we perform an ultrasound? Again, in addition to the indications on a mammogram or off a mammogram, you can see cancers and other abnormalities. The breast density does not affect it as much. And of course, it guides intervention, biopsies, marker placements, localization, and the patient is more comfortable with them being in the lying down position, with the breast not being squashed in a mammogram machine. Basics on breast ultrasound. It lets us indicate which site, a quadrant or an o'clock position. I would say think of 2 clocks side by side, but be really careful because what is 3 o'clock in the right breast is 9 o'clock on the left. And again, the point I'm making here is if a report states that it's in the 3 o'clock position on the right breast, also check where the marker truly is, because that's a place where mistakes can be made. Various descriptions for pathology in the breast: well-defined rounded or oval anechoic lesions are cysts, similar to the liver or the kidney or anywhere else, and a number of solid breast lesions go into the indeterminate BI-RADS 3 or 4A category and need biopsy. Now, I am aware that people are joining from all over the world, and I know BI-RADS is being used in a lot more countries. In the UK, this would be an M3 or a U3 rather on ultrasound. As far as the UK is concerned, this is what we have. We have a one-stop clinic where the surgeon does the examination. The radiologist, i.e. me, would be involved with the mammogram, the ultrasound, and guided biopsies. The sample goes to the pathology lab. There is a multidisciplinary discussion equivalent to the tumor board, and there is a communication of the results to the patient. So let's just look at a few cases just to what is radiology without images, right? So this is a 25-year-old woman with a breast lump, and she's come to the one-stop clinic. Here we can see that there is this entity here. And remember that normal nodes are reniform in shape, kidney bean-like, with a hyperechoic, which is more than the remaining parenchyma density, or rather echogenicity. So this is the hilum, which has fat, and the cortical thickness is less than 2.5 millimeters. So this is a normal intramammary lymph node. And this is a BI-RADS 1. No further evaluation is required. This patient would be discharged from the breast clinic. This would be a U1 in the UK. This is a 25-year-old woman again with a breast lump. And here you see that there is a right breast lump. The marker is in the region of the nipple. And it's a well-defined, rounded, anechoic lesion, no echoes within. There is some amount of brightness posterior to it because sound waves are allowed to transmit very well through the fluid within this cyst. That's through transmission, and therefore there is posterior acoustic enhancement. This is a benign lesion. It's a cyst. It's a BI-RADS 2 or a U2. I would offer this patient ultrasound-guided aspiration for symptomatic relief, and so that she goes away not feeling this lump. But beyond that, there's nothing more that needs to be done. Again, another 25-year-old this time, who has a left breast ultrasound. The marker is in the 4 o'clock position. This is a well-defined, oval, mildly lobulated, hypoechoic, less than the remaining breast tissue, solid lesion. There is some amount of through transmission, so you can see the area behind it is slightly bright. So posterior acoustic enhancement is present, but this looks like a solid lesion compared with the cyst that we had earlier seen. So this is a BI-RADS3. I would call this a U3, and I would perform a biopsy, or in some cases, a short-term follow-up is performed. I know some countries perform a short-term follow-up for this. And of course, I would discuss the biopsy at MDT, and if it's benign, the patient would be discharged. Another patient, this time with a different looking lump. There's a marker in the 2 o'clock position of the left breast. This is hypoechoic again, and it has irregular margins. There is posterior acoustic shadowing in this case, as opposed to the enhancement which we had seen so far. And this is a cancer. This is a BI-RADS5. It's a U5 lesion. I would do a core biopsy under ultrasound guidance, also image the axilla for abnormal nodes, and discuss the biopsy findings at MDT to guide treatment. This would be a T1, N0, because the axilla was negative on ultrasound, M0, stage 1 breast cancer. Now, this is another woman. She is 25. Again, she is breastfeeding, and a hypoechoic area, quite irregular, is seen near the nipple. The diagnosis is, now it has overlapping features with the malignancy as well, but putting the history together, and of course, we performed an aspiration under ultrasound guidance. This was an abscess. Follow-up ultrasound could be performed to check for resolution after antibiotic treatment. The learning point here is that ultrasound helps us in distinguishing between normal, benign, malignant, and infected breast lesions. Next on, the axilla. Again, ultrasound is very good for the axilla. Lymph nodes with uniform thin cortex less than 2.5 millimeters in my practice, but there are some units which use less than 2 millimeters and some less than 3 millimeters. These are normal or reactive lymph nodes. Again, the concept, the principle is, if we reduce the thickness, then the sensitivity increases, but the specificity goes down. Higher the thickness that we take, it's more specific in order to pick up metastases for cancer, if that is what is suspected. And however, it's less sensitive. Those that have a uniformly thickened cortex of more than 2.5 millimeters, these are indeterminate. I would give it an A3. Those with focal cortical thickening are more suspicious, maybe an A4. Rounded nodes with hilar attenuation, for example, this one, hilar attenuation, extremely thickened cortex, this is a malignant node, an A5. And of course, the other one is a replaced node with no fat in the hilum. That's obviously malignant as well. More than 4 or deeper nodes, I would also look at infraclavicular nodes going up towards the neck, and also the neck nodes, which may be abnormal in continuity. And this is an example of the same. We're seeing infraclavicular nodes here sitting underneath the muscle in the infraclavicular region of this patient who had breast cancer. And in contiguity, there are supraclavicular fossa lymph nodes as well, which look abnormal. They've lost their fatty hilum. They're just hypoechoic lymph nodes. Learning point, malignant axillary nodes may be due to breast cancer metastases, lymphoma, or other cancers causing nodal metastases. However, the imaging should be in continuity, particularly when breast cancer is known and you see nodes high up in the axilla. Just continue and image the supraclavicular fossa as well. Elastography is another technique that is used with breast ultrasound. It's a technique to look for tissue resistance. The principle being that stiffer tissues show higher values, as in this case. So this is a cancer which is showing this bright red in the center, which with really high velocities that have been plotted out here. Cancers are stiffer than benign lesions. Now this increases elastography increases confidence when performing biopsies. Perhaps not in this case, but certainly it improves our confidence in saying whether a lesion is benign, and if it is malignant, then where do we biopsy it from? Not everyone uses elastography. I am aware of that. So learning points. Mammogram helps in characterizing a mass as benign or malignant. It helps in characterizing. Still need to characterize it further. Ultrasound assessment is indicated in all such cases. Ultrasound, unless of course it's a benign lesion and it was previously seen on a mammogram from years ago, in which case there's no further evaluation required. Ultrasound is particularly useful for guiding biopsy, and where things are not seen on ultrasound but seen on mammogram, mammogram would guide biopsy. Elastography may be used to improve diagnostic confidence, as I mentioned. A word on male breast cancer. The appearance is similar to female breast cancer. It's seen in only 1% of cases. However, mammogram and ultrasound are imaging modalities that can be used for it. A little bit about calcification. Here you see on the right breast, in the right upper half, there is pleomorphic calcification. What do I mean by that? That it has different sizes, different shapes, different densities. It is in a segmental distribution, quite well seen on this CC view. It's in the form of a segment, which makes it more likely to be malignant calcification. So my grading for this is an M5 or a BI-RADS 5. I don't have any differentials for it. In fact, you can also see a mass lesion here. So I suspect that this has an invasive component as well, in addition to DCIS. I would go ahead and perform an ultrasound of the breast and axilla and a core biopsy, either under ultrasound guidance or, given the extent of this, I would perhaps do a biopsy of the solid lesion under ultrasound guidance. And if I'm not able to see the calcification on ultrasound, a biopsy of the distalmost point of calcification under mammogram guidance to ensure that the exact extent of the malignancy was mapped out in order to guide treatment. And this is what we saw. This is the area of the calcification and the mass that was seen there as well. So in this case, calcification was actually seen on the ultrasound as well. Calcification is usually only seen on mammogram, the exceptions being where calcification is seen within a malignant mass, or there is dense benign calcification, which of course we don't need to biopsy. I am aware that the next speaker is going to speak on CEM and MRI. So I thought I would just introduce and speak about CT staging for breast cancer, which is really not really required in most cases. When do we do it? In our practice, we do it when there are nodal metastases on primary imaging, that is 4+ nodes. If it's a higher stage cancer like a T3, T4, and if it's an inflammatory breast cancer. The symptoms, or the patient has symptoms in the form of cough, abdominal pain, deranged LFT, bone pain. And PET-CT is used to look for distant metastases in cases of recurrence. BSBR recently had a very nice webinar, a couple of really good webinars on advanced breast cancer and PET-CT, and inflammatory breast cancer and PET-CT, and also advanced imaging techniques in the form of PET and whole body MR for breast cancer. So please, if you wish, you can go onto the BSBR website and have a look. This is a CT showing right supraclavicular fossa lymph nodes, the same patient from previous where I'd shown you the ultrasound. Just going to a single slide for the MR of the breast, and indications are breast cancer not indicated for all, lobular cancers, yes, multifocal or multicentric cancers, and nodal metastases with no definite primary. Also for sizing mammographically occult cancer. Now, this is a case in point here. You can see that we have this marker here. This is, incidentally, this is a mag seed, and you can see that it is in an area where you can't really see a mass. Also, MR is performed as a baseline for patients receiving neoadjuvant chemotherapy, for example, HER2-positive patients, and detection of cancer in dense breasts. So this is a patient who has a lesion adjacent to the nipple, as you can see on the mammogram, better seen on the CC view than on the MLO view. And on ultrasound, you can see this lesion here sitting quite close to the nipple. And this turned out to be a lobular cancer. So we performed an MRI, and you can see that the lesion is much bigger than what it was on both mammogram and ultrasound. You can see the marker clip has been placed there, and you can see that it is in multiple locations, not just the one location that was seen on the ultrasound and the mammogram. I touched upon this, so let's proceed. Now, advances in mammography include tomosynthesis, which is the creation of a 3D image, or potentially you call it a 3D, it's not exactly a 3D image, of part of the breast by digital, of the part of the body by digital processing and using multiple X-rays. The exposure setting, there's something called 3D tomosynthesis. There's a 3D tomosynthesis with a synthetic view, and 3D tomosynthesis plus 2D, which of course will increase the radiation more than if a 3D tomosynthesis with a synthetic view is used. Now, this is more important radiologically when we are explaining things to the patient, but really it's a needs must kind of scenario, and where we think that it will give more information. It is completely justified in using whatever other imaging modalities we need with the radiation involved. Again, a little bit of technicality. It could be DBT slices and planes. This is what we talk about, or slab, which is a number of slices or planes combined to form a thicker section, and a synthetic view, which is a reconstruction of the DBT images to create a 2D image, which results in a lower dosage as compared to performing a 2D in addition to performing the tomosynthesis. So a 2D will be an additional exposure to the DBT. So as far as possible, we try to avoid that. The dose for a 2D mammography would be 2.8 milligray all in all. And for tomosynthesis, it would be about double. The compression would be similar to 2-view mammography. The equipment is slightly different in the form of a moving tube and a face guard on the main column. So the patient has to be told that there are things that are going to be moving around her or him. And this is an example of a mammography machine, while this is the tomosynthesis machine. And this is how it moves around the patient, taking images at multiple sites. And overall, the computer generates the slabs, and that is how we see where a lesion lies at what point in the breast. Indications for tomosynthesis. In our practice, it's screening detected soft tissue abnormalities, which could be a mass, a distortion, or asymmetry. On the symptomatic clinic, it is used on a case-per-case basis. For example, for dense breasts, for multiple lesions, for mammographically occult lesions, mammogram-guided procedures, and also screening in high-risk women for the Prospects trial. Just to show you one case, this is a surveillance mammogram on with a suspected cancer, a single lesion, and a further lesion was seen on tomosynthesis. So you can see the surveillance mammogram, this is the present one. So this is what was done now. And in comparison with the MLO view, this is the present one, that's the previous one. You can see that the density is increased in this area in the upper left breast. That was the site of suspected cancer. And when we performed a tomosynthesis, I'm just showing you the MLO view in the interest of time. And you will see the cancer coming up, marked by an arrow. Everything seems very slow. So that is the cancer that you can see quite well. And then if you look further, so you've seen the cancer, and then you look and you see another little entity coming up here. And that is the second cancer. And we saw this, this was the area. I'm not going to run this loop now. The second lesion was in the left upper inner quadrant. So this was really a multicentric cancer, and that guided treatment appropriately. So these are the two cancers, cancer 1 and cancer 2. Also, breast intervention, it's one of those things that lends itself very well to our basic imaging modalities, mammograms and ultrasounds. Fine needle aspiration, rarely ever done for the breast, but it's one of those things that can be done. For example, cyst aspiration for symptomatic cysts. Biopsies, core needle biopsy, vacuum-assisted biopsy, or excision even of benign lesions, or with the small trial, small cancers, which are grade 1, and they can be excised completely using vacuum-assisted excision. Tissue marker placement, localizations with wires or non-wired localization, and newer non-wired localizations, and of course, therapeutic aspiration of cysts or abscesses. Just touch upon breast biopsy, and essentially what I'm talking about is ultrasound guided breast biopsy. The target lesion for biopsy is seen in real time. It increases accuracy, allows for better sampling. There is safety because there's needle visualization and safety of the adjacent vascular structures. And this is especially important when the patient is on anticoagulants. So it can be done under ultrasound guidance reasonably safely. Accurate tissue marker placement can be ensured. And of course, it guides a decision for localization. If the lesion is seen on ultrasound, it can be localized on ultrasound. It's done under local anesthetic with risks and complications explained to the patient, also need for further biopsy, also explained to the patient. Clear post-procedure instructions are given and results are discussed at MDT. This shows the breast biopsy, core biopsy needle in the lesion within the breast. It uses a 14-gauge spring-loaded needle. The cores are sent in formalin. FNA has very few indications. For example, if it's a deep-sited lymph node close to blood vessels in a patient who is on anticoagulation. Otherwise, anticoagulants, even the newer anticoagulants, are not really a contraindication for breast biopsy. Core biopsies, I am alluding to. Axillary biopsy, again, similarly. This is the equipment, or rather the needle, for a vacuum-assisted biopsy. And the thing that I'd like to draw your attention to, forget about all the rest of the stuff, but there's this needle with the open notch, which is this, which is connected to the blue handpiece. And this has a 20 millimeter aperture. And this is a 9-gauge needle. So vacuum assisted biopsies could be 7-gauge, 9-gauge, 10-gauge, 11-gauge. It gives you a much bigger, it gives us a much bigger sample, and it can therefore be used for excision biopsies. Tissue marker placements, indications are cancers in that we plan to subject to neoadjuvant chemotherapy, or in high-risk patients treated with first-line endocrine treatment to check response to treatment, and small, impalpable, screen-detected or incidentally found breast cancers, and of course, multiple cancers biopsied to confirm disease extent. Tissue marker placement, again, further, you can use it for DCIS, lesions only seen on MRI, marking of involved lymph nodes to guide during surgery, and also for certain cancer trials. Currently, the ones that are in use are titanium or stainless steel. These are also MRI compatible. They may sometimes be embedded in a collagen or a polyvicryl material, which is sonographically visible for several weeks. And that allows subsequent ultrasound-guided marking of these, particularly where the lesion may have disappeared on subsequent imaging with the following neoadjuvant. Some clip markers have a small amount of nickel. These are not used in patients with nickel allergy. Just a few examples of tissue markers. Localization, again, similarly, where we have put in tissue markers and turns out to be a cancer, we can use we can localize those to guide surgery. And again, similar indications as tissue marker placement. Just some examples of needle wire systems, 16 to 20 gauge, and they can have various hook, barb, pigtail configuration as ends to anchor. Non-wire localizations, these are a few. Iodine 125, radar reflectors, magnetic seed markers, and RFID tags can be done before the surgery. That's the advantage of it. And they emit real-time audio and visual feedback that aids as the surgeon continues the dissection. And you are obviously aware of this. There are a lot of you that are using this. Just an image that I couldn't help showing you. This is a marker. This is a mag seed, which is placed in this lesion in the inner right breast. And that film shows you a tissue marker, which is inserted at the site of this microcalcification, which was biopsied. It turned out to be DCIS. You can see that there is a hook end wire that is placed to help guide the surgery. You can also see that there is a mag seed that is placed there. Unfortunately, the mag seed is not in the right position on the other view, and that's the reason why the needle, why a wire was also needed. The other mag seed is in a good position, so that was all right. Where we speak of mammograms, we also have to speak about specimen x-rays to look for calcification, and also the surgical specimen x-ray, which is showing the mag seed and the lesion that has been excised. I'm nearly at the end of my presentation. I think I've run over by a few minutes. Thank you so much.
It's been a great talk. Yeah, it's great talk, Tripti. Lots of feedback already on the webinar chat. I had a few messages. I had a message from Prof. Arnie Purushottam from Guys to say, great talk, up to the point, and love the learning point slides. Lovely talk, Tripti. We'll take all the questions at the end. If you want, there's some questions on the Q&A section. So if anybody wants to ask questions, please put them on Q&A section. Otherwise, we will not find them on the chat. You can see how busy it is. And we have 550 people online. Now we have the next speaker. So we have Simon Lowes, and he's going to talk about CEM versus MRI scan. I'm going to share the screen. And Simon, I've been told by Gerald, he's been appointed recently as the Roentgen Professor of the Royal College of Radiologists. Am I correct in saying that? Did I say it correctly? Will I say it funny?
It's the Roentgen Professor, yeah. So it's named after Wilhelm Conrad Röntgen, who discovered X-rays back in the early 20th century. So
Perfect.
thanks so much.
The next 15 minutes are yours, Simon.
Brilliant. Yazan, I might be able to share my slides now. Actually, I've swapped laptops.
Oh, yeah, that's fine. Yeah.
So I'm going to try if that's okay.
Yeah, give it a go. If it works, that's lovely. If it doesn't work, then I will share from my side.
Brilliant. Thanks.
And people online, please, if there's 4 channels today, there's Spanish, Italian, Russian, and Arabic. So please, if you're using those channels, leave me some feedback to see if I'm sure that that's helpful, but I need to get some feedback also to maintain the channels. And also, if you have any questions, please put them on the Q&A section.
Brilliant. Well, I'm trying. Okay, it doesn't seem to want to let me connect, but never mind. But if you wouldn't mind sharing, that would be fantastic. Thank you very much.
Let me see if it works now on my side, because
I know, sorry. Everything looked like it was going to work, and now there's some weird privacy settings thing I haven't apparently.
Yes, that's unfortunately. Yeah. Let me see if I can share, because I also messed up things here.
I'm so sorry if that's the case.
Oh, no. That will be all fine. Now I'll share this. Can you see the screen? Can you see my screen?
Yes. I can see it. That's excellent. Brilliant.
Yeah.
Perfect. Thank you very much. Yeah. So thanks, Yazan, for asking me to talk today. It's an absolute pleasure to be here. It's incredible to see so many people who have joined the webinar and from so many different parts of the world. So it's really exciting. Thanks very much. So I'm a consultant breast radiologist based in the northeast of England, and I work with all of the other radiologists in various capacities who were on the webinar today, including Gerald and Tripti as part of the British Society of Breast Radiology Executive Committee. I also work with Yazan as well as the radiology lead for the iBreastBook Localization Committee. So my talk follows, I think, fairly nicely on from Tripti. She set the scene very well. And once again, I've tried to keep this pitched at a level that is applicable to everybody, I hope. So we're going to be talking about contrast enhanced imaging. And actually, if you go back to the first slide, if that's okay, Yazan, because I've depicted this, the name of the talk was MRI versus CEM, and that implies that there is a competition between the two imaging modalities, and that somehow one will win out over the other one. But over the course of the talk, I hope to try and address whether that really is an issue or not. So next slide, please. So contrast enhanced imaging, and that encompasses MRI, it encompasses contrast enhanced mammography, allows us better disease discrimination than the standard imaging techniques like mammography and ultrasound that we've heard about already. The reason for this is it exploits tumor neovascularity, and it also exploits the fact that not only tumors do they have increased blood supply, they also have leakier vessels as well. So that allows contrast agents, intravascular contrast agents, to access the tumor and highlight them on different imaging modalities. Because of this, to do contrast enhanced imaging, you need to have an intravenous contrast agent. Next slide, please. And this is just an image straight away of an MRI. We're going to talk a little bit about what these imaging modalities look like in a little bit more detail, but this just illustrates a MIP image, so a maximal intensity projection image of an MRI scan with a tumor in the inner half of the left breast with a large feeding vessel supplying it. And this arises from the left internal mammary chain. And this just exemplifies the prominence of the neovascularity of breast cancers. Next slide, please. Everyone will be familiar, I'm sure, with both techniques to some extent. When we do breast MRI, we use a conventional MRI scanner, but the difference is that we use a breast coil. So this means that women have to lie prone on the table, and you can see the breast coil, if I can get my pointer to work, here, which is gray, and it has 2 holes within it that allow the breast to fall through gravity into the coil, and that allows us to be able to visualize the breast tissue with sufficient resolution. With contrast mammography, it's done on a standard mammogram machine. The only difference is that it's adapted with a special software to allow it to interpret contrast enhanced imaging. So both types of modality should be fairly ubiquitously available in most breast units. Next slide, please. And I mentioned contrast, intravenous contrast. For MRI, I'm sure you're all aware, we use a gadolinium-based contrast agent. We use Dotarem in our unit for breast imaging. And for the contrast-enhanced mammography, we use iodinated contrast. And this is exactly the same contrast, the same concentration, and the same dose that you'd use for intravenous contrast for CT examinations. Next slide, please. So this just gives an overview of some MR images. And on the left, the good thing about MRI is we get lots of different sequences, and we can look at the breast tissue in lots of different ways. So on the left, we have a T2 weighted image, and most people are familiar with a T1 and a T2 weighted image. And the T2 weighted image here allows us some anatomic discrimination of the different structures within the breasts, and also to some extent within the chest wall as well. And in the inner half of the left breast, we can see anatomically, we can see a tumor. And within that, there's a little bright area, which is the gel capsule around the marker clip. So this is a hydromark clip that we commonly insert, as Tripti mentioned, after we do a biopsy. And this remains visible for many months. So if we were going to monitor this patient with neoadjuvant chemotherapy and were to watch that tumor disappear after they've had chemotherapy, we'd still be able to see that little marker clip at the end of the treatment, so we could help the surgeons to accurately localize that tumor bed. And we can see the fat, as I mentioned. We can see some scattered fibroglandular tissue, these little strands here. And in this case, because of the fatty breast tissue in the background, we can see the tumor really well, but that's not always the case, and that's where contrast comes in. On the right, this is the post-contrast images, and again, we can see this avidly enhancing tumor in the left inner half. If you don't mind, next slide, please, Yazan. Thank you. And one of the good things about MRI, and again, these are T2 weighted images, so we're just looking at the background anatomy before we've given any contrast, is we can not only see the tumor in this case, but we can also look at the axillary nodal disease burden. We can look at subpectoral nodes and internal mammary nodes as well. So it gives us a little bit more anatomic information about the extent of disease. The other thing about MRI as well is it gives us any information on chest wall involvement. So it's not that common for tumors to involve the chest wall. More often than not, they don't. But when they do, then MRI will allow us to evaluate that, again, aiding the surgeon in deciding the best form of management. Next slide, please. And so this is when contrast really comes into its own. So again, on the top left, we have a T2 weighted image of the breasts. This doesn't have any contrast on board. And this patient has fairly dense breast parenchyma and is fairly symmetrical in both breasts. The red arrow is pointing to where the tumor is, which to somebody who reports a lot of MRI, I think it's impossible to discriminate that tumor from the background breast tissue without contrast. But then when we look at the image on the top right, this is the contrast images. So this is a T1 fat saturated subtracted image. It takes away everything except the contrast. We can see this large wedge shaped area of enhancement, which corresponds to a large lobular carcinoma. And the other thing to point out in this patient as well, I'd mentioned we can look at subpectoral nodes and axillary nodes. This red arrow here, it's actually very difficult to see, points to an internal mammary node that's pathological. Next slide, please. So I mentioned the thing about MRI, it gives us lots of different sequences, and we can look at the breast tissue in lots of different ways. We can also extract things like time enhancement curves. So malignant lesions have a different pattern of enhancement over time to benign lesions. We can do other techniques such as diffusion weighted imaging. And these all add on to the length of time and the complexity of the different MRI investigations. But on the other side of the spectrum, we're now looking at actually, rather than increasing the number of sequences and complexity, we're actually looking more and more at abbreviated protocols and their utility as well. Next slide, please. So in contrast to MRI, contrast-enhanced mammography is actually pretty simple. We don't really get many images at all. We do two sets of images, so it's called a dual energy technique. And we do some low energy images, which are basically like standard mammograms, and we do some high energy images, which I'll show you in a second. We do standard views of both breasts, so as Tripti covered, we do MLO views and we do CC views. And we give intravenous contrast, we give that iohexol, that iodinated contrast, we wait 2 minutes, and then we acquire our images. We normally just do a single time point acquisition, unlike MRI. So after we've given contrast, we do our standard low energy images, which look like this. So they don't look any different after we've given the contrast at all. But what I will say is that this patient has a tumor in the the upper half of the right breast, which is here on the MLO, and it's here where the mouse pointer is on the CC view. As soon as we've done the low energy image of each breast, we do a high energy image. And this is designed to basically interact with the iodine that's present in the contrast. And then the software algorithm gives us a nice subtracted image that shows us where the tumor is. So Yazan, if you put the next slide on, this should be a subtracted image. And this shows us that you wouldn't necessarily appreciate that tumor on the low energy images, but there's a large avidly enhancing tumor in the upper half of the right breast. And this is a lobular carcinoma. And anterior to that tumor, there are lots of other little foci of enhancement as well, which turned out to be malignant disease as well. These would have never been seen on the standard low energy views. The other thing to point out as well is one of the things that complicates our interpretation of contrast mammography is that many women, particularly those who are perimenopausal, is that they tend to have a lot of background enhancement. So if we look at the other breast as an example, the left breast, we can see this sort of cloudy, subtle enhancement as well. And this can sometimes complicate our findings. It can sometimes make diagnostic interpretation of the extent of disease difficult. Next slide, please. So on the right are the images we've just looked at, this enhancing tumor with its satellite nodules, and on the left is the equivalent image on the MRI. So same patient, within a week of one another, you can see what the different modalities look like. Next slide, please. So before we look in a little bit more detail about what different lesion types look like on MRI and contrast mammography, before we think about the different clinical indications, there are some obvious practical advantages of contrast mammography over MRI. First of all, in general, CEM is more accessible because mammography equipment is greater in number and generally more ubiquitous than MRI. Overall, it's cheaper. It's quicker to perform. It takes a matter of minutes, whereas MRI can take 20 to 40 minutes, sometimes even longer. It's generally quicker to report because there's less complexity there overall, fewer images for us to look at and interpret. And overall, there are fewer contraindications. So all those things like metallic implants, neurostimulators, pacemakers just aren't an issue with contrast-enhanced mammography. The other thing to bear in mind is that patients actually prefer contrast mammography over MRI. There have been a number of different studies, and we've done it ourselves in our unit, looking at, because we do both CEM and MRI in all of our patients, we're at an advantage because we can actually ask patients which they prefer. And they pretty much universally prefer contrast-enhanced mammography over MRI, mainly because it takes less time, it's less claustrophobic, it's less noisy, they've got direct contact with the radiographer throughout. And even though the contrast agent feels a little different, and arguably the effects are more noticeable in patients when they have iodinated contrast, that doesn't seem to be a problem. Next slide, please. So then moving on to the clinical indications. Now, as Tripti covered, there are a huge range of different common indications for looking at MRI. As we covered at the very beginning, the purpose really is to give us that additional information over what standard mammography and ultrasound give us. So things like mammographically occult breast cancers, when breasts are dense, they don't give us all the information we need, when there's a size discrepancy between standard mammography and ultrasound, with lobular carcinomas, which we know have a different growth pattern to ductals. They tend to be more likely to be mammographically occult, multifocal as well. And as Tripti mentioned, and I alluded to earlier as well, one of the biggest workloads we have for MRI is for assessing response to neoadjuvant chemotherapy. And with the years, we've looked at our MRI workload. It's grown a huge amount. And the main reason for that is the increase in the amount of neoadjuvant chemotherapy we're giving to our patients. Other indications, general problem solving. When we haven't got an answer, MRI will give us more information. And similarly, Paget's disease as well. We don't see that huge amount, and there's a bit of controversy about how much information MRI gives us, but we tend to do it for those patients as well. And as I mentioned, for every indication in our center that we do MRI, we also do contrast mammography. Both modalities also allow us to do contrast-enhanced biopsies as well. So as well as looking for indications for biopsy-proven malignancy, there's also a role for screening and surveillance in those who either don't yet, but may have breast cancer in the future, or have had a previous breast cancer. Thank you. Next slide, please. Another role as well as doing those standard indications for MRI, is the potential to use it in a one-stop setting. So again, to supplement those additional mammograms and ultrasound, we could potentially just whip patients off in the same visit to their symptomatic presentation and do contrast mammography at the same time to give us additional information. And that's a model that's been used by a group in Nottingham for 12 or so years now, and they've reported on it, they've published on it. It's not something that's worked particularly well in our unit just because of logistical issues, but it's something, it's another potential application for it alongside standard mammograms and ultrasound. Next slide, please. So how many people use contrast-enhanced mammography? Well, a group representing USOBI did a survey, and they had over 400 responses to the survey, and they asked about various aspects of CEM usage, and they found about 50% of centres currently use contrast mammography. But because of the fact that lots of centres already use MRI, they can sort of satisfy those needs for additional contrast-enhanced imaging. The general impression was that it tended to be more useful for those patients where they couldn't do MRI because, for example, of contraindications or intolerance by patients. Only around 2% of respondents felt that CEM would entirely replace MRI in the future, but around 40% felt that CEM could replace MRI or was likely to replace MRI for certain indications. Next slide, please. So this just gives some examples of MRI versus contrast-enhanced mammography, just to show you some idea of how the tumors look similar and how they might look different on the two different modalities. So the top image on the left shows an invasive ductal carcinoma, which is grade 3. It's ER positive and HER2 positive. So this patient was going to have neoadjuvant chemotherapy. She's a 72-year-old. She has a unifocal tumor in the upper central right breast. And it looks fairly similar and measured similar in size as well on both modalities. And after neoadjuvant chemotherapy, you can see on the lower left image that there's no residual tumor. So we call this a complete radiological response on MRI. There's also no tumor left on the contrast-enhanced imaging either. So we call it complete radiological response on contrast mammography. And subsequent surgical excision can confirm that it had a complete pathological response as well. Next slide, please. So this is another invasive ductal carcinoma, this time in a 62-year-old lady. She had an ER negative HER2 positive cancer. Again, a very similar looking tumor in the right breast before neoadjuvant chemotherapy. This time, though, there was a tiny residuum of tumor present. Quite difficult to see, quite subtle. That's why I've used the red arrows to try and highlight it. We measured it as 13 millimeter residuum on both the CEM and the MRI. The pathology, after it was excised, confirmed a residual 7 millimeter invasive cancer, but it was 25 millimeter tumor size in total when DCIS was included. So that's an example of a partial response. Next slide, please. So this is another example of an invasive lobular carcinoma. So if you look at the top set of mammographic images, top left hand side of the screen, you may see that in the left breast, and I'm going to highlight it if I can. There's an area of density in the upper outer quadrant of the left breast, which looks subtly different to the right breast. Oh, sorry, is that? And it's hard, not impossible to see without zooming up, but there's also an area of branching pleomorphic malignant microcalcification associated with that area as well. Overall, though, it's quite difficult to see. There is an asymmetry, but we can't fully appreciate the true extent of disease on the standard low-energy mammograms alone. And then at the bottom, you've probably already seen it. But this is what it looks like when we, in the recombined image, which shows the full extent of disease. So actually, this is a really extensive lobular carcinoma that occupies a large proportion of the left upper outer quadrant. It extends close to the nipple, but importantly, it also has additional foci as well, both inferior and medial to the main index carcinoma as well, which was proved to be malignant on further biopsies. And similarly, when we look at the MRI in the bottom right-hand corner, this is the MIP image post-contrast. This really highlights the extent of disease as well. One of the things about MRI and contrast mammography, and this is one of perhaps the controversies that's unresolved at the moment, is the extent to which each detects additional disease. You might think just by looking at that MRI that you've got better resolution of the image, and it identifies a greater extent of these additional foci as well. And that's something that, as an anecdotal thing, I tend to appreciate when I'm reporting both modalities. But I think that there's no unified agreement on whether one is better than the other in terms of identifying all of these additional foci. So next slide, please. So we've talked a bit about the practical advantages of CEM over MRI, but there are some immediate disadvantages as well. We looked earlier at some examples of how MRI allows us to quantify the extent of axillary, subpectoral, and internal mammary disease. CEM just doesn't allow you to do that. It doesn't allow us to assess chest wall invasion. So, for example, the images on the right demonstrate a tumor that is contacting the chest wall and did show some invasion, but the most important thing about it is it's very posterior in the breast. So the top image shows the T2 weighted image. The bottom shows the subtracted fat suppressed post-contrast image. And the bottom images show the contrast mammograms. And you can only just barely see it, as indicated by the red arrow at the back of the CC view. Otherwise, you wouldn't have perceived this tumor at all on contrast mammography. But that said, we tend not to do MRI to assess axillary disease burden. Yes, we get that information, but it's not a primary reason. Ultrasound is our gold standard for assessing axillary disease. The other thing is we don't get other findings outside the breast either, which again is not an indication of MRI. Sometimes these are found incidentally. But generally, once we do ultrasound, once we get a feel for the full extent of disease, we tend to then progress into CT staging to look at those things in more detail. So by not doing MRI in these cases, we don't necessarily miss out on that additional information. I mentioned we only do a single time point for CEM versus MRI. You can actually do more than one time point, but we tend to do one single time point. If enhancement curves are really important, and some radiologists would argue they are, then that's obviously something we're missing out on. But as we move to abbreviated MRI protocols, they actually only do one time point as well. So you could argue that moving to more abbreviated MR imaging is pretty much the same as contrast mammography in that regard. There's a relative contraindication of doing CEM with implants. The machine tends not to like it very much, but it's not an impossibility. And of course, iodinated contrast has a higher risk of contrast allergy than gadolinium-based contrast agents as well. Next slide, please, Yazan. But an advantage of contrast enhanced mammography over MRI, as well as the practical advantages, it allows correlation with microcalcification. So sometimes the microcalcification is more extensive than the enhancing area, than the tumor. Sometimes it's just unclear whether large footprints of calcification correlate with the tumor on MRI. CEM has that immediate advantage that allows us to do that. And this is probably quite difficult to see, but this patient, the left two images show pre-neoadjuvant chemotherapy imaging zoomed in. It's a CC view, but it shows a footprint of microcalcification which overlies the enhancing tumor. Post-NAC, again, the very far images probably best illustrates this. There was only a subtle area of residual enhancement. It's virtually imperceptible, but there's still a residual footprint of microcalcification there, which we can immediately report on the contrast mammograms. We couldn't appreciate that. We never would be able to appreciate that on the MRI. And actually, when reporting this, we commented on the enhancement, 17 millimeters in contrast mammography. There was nothing at all, no residual enhancement on the MRI, and the surgical excision confirmed that there's 20 millimeters of residual invasive ductal. Next slide, please. So overall, which is better? We've gone back and forth a little bit, looked at examples of both modalities, talked about some practical advantages and disadvantages, which is really important in terms of how we work, in terms of our workflow, in terms of patient preference and so on. But which is better when we look at the evidence? Is MRI better than contrast mammography in terms of disease detection? Well, that's a very difficult thing to answer. And as I've depicted here, the jury is still out. Next slide, please. As you might expect, over the years, if you do a very basic PubMed search, you can see the number of publications continues to rise every year as we get more and more information on both modalities. And there have been various different studies. Actually, if you skip through a little bit, Yazan, I mean, I've highlighted, next slide, please. And the next one and the next one. I'm probably not going to go through all these individually anyway, but these are just examples, very select examples of the many different studies that look at contrast mammography, comparing it with standard mammography, comparing it with MRI, and they all give various opinions. And there have been some meta-analyses done to try and work out which one is superior, but by the time you look at all of your exclusion criteria, by the time you've decided what your endpoint is, you've tried to standardize all the studies you're looking at, you tend to be left with very few studies to actually compare. So the jury is definitely out. There's no single advantage really of contrast mammography over MRI. Maybe as we have more data, then we'll be able to be a little bit more conclusive. Next slide, please. But overall, as things stand at the moment, there's no one modality that's definitively better than the other one. It's largely down to personal preference. There's probably a lot of variability in local interpretation of the two modalities as well. Overall, though, contrast-enhanced imaging gives us much better disease mapping than standard mammography and ultrasound. Both MRI and contrast mammography have utility for the same applications, but they both have their own advantages and disadvantages, both practically and in terms of diagnostic interpretation. Next slide, please. So I started at the very beginning with these two modalities competing against each other. Next slide, please. But I think rather than there being one outright winner, it's a case, at the moment at least, of using both modalities together to give the best outcome for patients. Thank you very much. I hope I haven't overrun by too much.
That's lovely, Tuk. Thank you for that, Simon. So if you have any questions, please put on that Q&A function. We're slightly behind scheduled, but we'll try to go through as many questions as we can when we get to the discussion. Now we'll change the order of the list a bit because Tay will go next, and Will is going to talk about risk-stratified screening. And Will is one of the radiologists in London, and for his sins he works with me on Fridays. So that's he's going to talk about risk-stratified screening. Will, the next 15 minutes are all yours. I can't hear you, Will, if you're starting to talk.
Okay, can you hear me all right?
Perfect. That's much better now.
Good, excellent. All right. So what I'm going to go through is just really revisit the principle of screening, because I think we're so used to doing screening. I think it's probably just worth knowing why we screen and what are the pitfalls possibly, and also take you then forward from population screening to risk-stratified screening, concentrating on high-risk screening and dense breast, which is obviously an ongoing debate. So the principle of screening is enshrined from the original WHO document and policy document back in 1986. And I think it's worth looking at it. Essentially, it needs to be a problem or disease that is common. There should be an acceptable treatment for it, because there's no point in screening for a disease early if there's no treatment for it. Facilities for diagnosis and treatment should be available, and there should be a stage that we can identify it, and the test needs to be acceptable both to the population who's been screened, and also it should have an appropriate accuracy, sensitivity, and specificity. There should also be an agreed policy in whom to treat, and there should be an ongoing case finding in terms of a process of learning and quality assurance, which is what we built into the program. Now, I'm going to apologize ahead because this is going to be a very UK-centric talk, because much of what I'm talking about is the policies and the screening policies in the UK program. So does breast cancer fit the remit? Well, it does. It's a very common disease, particularly in the developed world. In the UK alone, we had just under 56,000 cases in 2019. And just under 12,000 breast cancer deaths a year. And it's the second most common female cancer in the UK. Do we have an acceptable screening tool to detect breast cancer? Again, yes, we have. Very difficult to do a randomized control trial now in terms of breast cancer diagnosis and detection, but we do have the two-county trial. The most recent update, which was back in, as you can see, in 2011, shows that actually the relative risk of dying from breast cancer opens up to from about 20 to 30 years after screening, and you have a 31% reduction in breast cancer mortality, and that's using mammography. And there's also been a very useful follow-on from the two counties trial, which was published in 2021, 4 years ago, which shows the obvious. It may be obvious, but where here we have on this graph here in green are the people who attended for screening regularly, and all the way to the red, where you have the people who do not participate at all, and in between what we call the lapse attenders, so people who attend intermittently. And not surprisingly, the people who come for screening regularly has got an opportunity of having their disease picked up earlier, and therefore breast cancer mortality is reduced. And those people who are invited but not screened will tend to then be exactly the same as symptomatic, i.e. they're not picked up early. Here is the chart of the evolution of the UK screening program. It started back in '86 following the earlier publications of the randomized control trial, and concluded that it's actually economically and from the health policy point of view, good to go for population screening, age 50 to 64. There's been then an evolution in terms of the technology that we use. And in 2013, about 10 years ago, we then introduced a high-risk screening program, which I'll go into more detail afterwards. And this year, we have re-extended the screening program for the high-risk group, 25 to 70 years of age, as opposed to starting from 30. So having got the screening program, we need to make sure that we invite as many people as possible and try to encourage people to attend. Like vaccination, you only do good if more people attend for screening. So we have to invite and inform what they let themselves into, test and screen them. We need to allow access for those who have difficulty, for instance, those with wheelchair, learning disability, etc. And it's no good having a screening program if we can't get the results out in good time and screen them in good time. And we also need to make sure that we're performing according to a program that we set, and the quality and the standards we set ourselves. So quality assurance is a very, very important part of it. So in the UK, we do population screening, which is what we call the NHS breast screening program. We currently invite them from 50 to age 71. It's a 3-yearly program. There's also targeted screening that's come online now, where we are designating and targeting a very discrete population. So this is not breast screening, but for instance, the lung health check care screening program is coming in, and it's already being rolled out. It's targeting smokers or ex-smokers 55 to 74. So we're targeting a very discrete group of people with a discrete group of risk factors. And what I'm going to touch upon next is the risk-stratified screening, where not only we're targeting a specific group of risk, which is a high-risk group, but it also varies in frequency. So we're doing yearly as opposed to 3-yearly, and according to modality. And it's good that you've already heard about MRI, because it's where MRI screening comes into for the high-risk group. So the high-risk group is when worth talking about the risk factors of breast cancer. By and large, for the general population, the largest risk for breast cancer is age, like most other cancers and disease that we suffer from. And you can see roughly the risk of breast cancer is not zero for the under 29, but it's a lot lower compared to going up to age 69, where it's 1 in 13. There are other risk factors, both sort of lifestyle and non-lifestyle. Hormonal, for instance, early periods, late menopause, prolonged HRT, and oral contraceptive pill, obesity, alcohol smoking, and all the way to the preventable factors as well as the non-preventable factors. So the other risk factors I'm going to talk about, concentrate now mainly, is really twofold. Those with dense breast, those women who've had radiotherapy aged between 10 to 35, and the ones with family history, both with genetic predisposition due to pathogenic variants of known breast cancer genes, which most people will know, the BRCA1 and BRCA2, and then the others which we now know about, such as PALB2, CHEK2, BARD1, and the rare syndromic cancers like leukemia. So family history, first of all, in the UK, we divide them into population risk, i.e. no risk factors or only one first-degree relative over the age of 40 with breast or ovarian cancer, the moderate risk group, as you can see here, and the higher risk group. So what do we do with them? Well, first of all, we need to evaluate the risk. We can do, so we can test them genetically. And also there are other breast cancer risk assessment models that we can utilize, of which there are many. So we've got the GALE, which are predominantly developed in the white women, extend to Afro-Caribbean and Hispanics. We have the BCSC and the CLOUDS. And then we've got other models predicting genetic risk, such as the Myriad and the Manchester scoring system. And the ones that we tend to use more in the UK, it's a combined breast cancer and genetic carrier risk models, of which the CAN risk, which is probably Rhodesia, is now being rolled out and commonly used in the UK and determines whether or not they enter the screening program in terms of high-risk screening. What do we do with them once we stratify them? We've got the low population group. So here you have the lifetime breast cancer risk, less than 17%, and less than 3% 10-year breast cancer risk, age 40-49. These are the population risk group. So in the UK, they enter the program at age 50 to 71 and every 3-year screening mammograms. We've got the moderate risk group and the high risk group that I'm going to concentrate on. The moderate risk group are those with less than 30% lifetime risk. And you can see our screening protocol is to screen them from the age of 40 to 60 annually, and offer them mammography. And after that, from 60 onwards, we offer them the 3-year NHS program. When we started the UK NHS screening program for the high-risk program in 2013, there were the 4 main genes that we screen them for. There's a BRCA1 and BRCA2, the TP53, and the AT genes. And you can see here that the screening protocol started at the age of 30 originally for the BRCA1 and BRCA2 using MRI, adding mammography at the age of 40, and then carrying on until the breast density drops to adipose or Barrett's A. The TP53, because it's a so-called brittle gene syndrome, we do not, unlike in the US, screen them with mammography. We use annual mammogram from the age of 20. And then you've got different regimes for the AT homozygote and the AT heterozygote as well. Now, one of the differences, I think, in the UK, which is relatively unique, for instance, Ireland doesn't do this, is that our high-risk screening does not just encompass the genetic mutation carriers, we also encompass those who had radiotherapy from the age of 10 to 30, as it was then back in 2013. So we include them into our high-risk program, and we don't just screen the genetic mutation carriers. So roll on 10 years on, you can see that we've learned a lot about the pathogenic genes. We now include the PALB2, the CHEK2, the PTENs, STK11, DHON1, all with its own stratified screening program from the age. As you can see here, we've got TP53 untested, and all the others that you can see here. And it carries on to the risk equivalent untested. We also have a regime for testing those women. For the radiotherapy group, we've extended the age group to the age of 35. And you can see here that we now acknowledge the fact that the women who had radiotherapy less than age 20 are at highest risk. So we start them from the age of 25, and those from 20 to 36, we start them from the age of 8 years from the radiotherapy, whichever comes first. So we can see we have, again, MRI, adding in MRI and mammography from the age of 40. So it's a very stratified modality depending on what risk factors they carry. So what have we found so far? In the latest year, 2023 to 2024, in England, we had screened just under 12,000 high-risk women, of which nearly 2/3 are BRCA1 and BRCA2. And it's worth showing that SRT group, which is a radiotherapy group, composed of about 17% of the groups of the screening. And the others are a much smaller number, as you could expect. In terms of cancer detection, the BRCA1 and BRCA2, you can see that in terms of cancer detection rate, there are about 20 to 22 per thousand women screened. Bearing in mind the UK NHS screening program for the normal population is 8.5 per thousand women screened. So this is 3.5 times the incidence of breast cancer in the normal population that we pick it up. Interestingly enough, the radiotherapy group is not that far behind. There are also about 20 per thousand women screened. And here on the right-hand column, you can see that's the invasive cancer detection rate. So really not that far off the BRCA group. Worth knowing, if you look at the non-tested but high-risk group, where they have not been proven to be genetic mutation carriers, the incidence of cancer is a lot significantly lower because they are quite a varied group. Because the majority of these women probably do not carry any pathogenic genes. I'm going to roll on now to breast density. Here's an example of breast density. On the left-hand side is breast density A, very, very fatty. All the way to the right-hand side of the screen, very, very dense breast density D. B is mixed fibrogranular, and C is moderate breast density. Now, remember I said that this is now rapidly becoming a very important area of research in terms of risk-stratified screening. Why? Well, it's a known risk factor of breast cancer. I've already said it to you. And how is it important? Well, if you compare the incidence of breast cancer risk, if you've got a very high group, which is D, you're 4 times more likely than the fatty breast to get breast cancer. And even compared to B, you're twice as likely. Women between age 40 to 49 have got roughly up to 50% incidence of dense breast, so it's common. 9% of women have extremely dense breast in the 50 to 70 age group, and not only they're more likely to have breast cancer, they're also less likely to be picked up on the standard tool we have for screening, which is mammography, because the breast density makes it more difficult to see. We've looked at the North London population using the AI retrospective trial, and we can see that the interval cancer rate for A and B is roughly less than 1 per thousand. When you compare to C and D, it's 2 per thousand women screened. So there's actually proof that women who've got higher breast density have got a higher interval cancer rate, i.e. they are less likely to be picked up by screening and more likely to be detected symptomatically. There's also a suggestion in some papers that the local recurrence rate post breast cancer treatment is high in dense breast, roughly 1.5 to 2 times higher after breast conserving surgery. So the risk does not decrease after treatment for breast cancer. It certainly seems to be maintained. So here we have a graph showing some multiple trials, which shows that there's decreased sensitivity in using mammography as screening compared from A, B, C, and D, the sensitivity drops. And you can see from this, this chart here, the relative risk of breast cancer compared to B, C, and D. And you can see that the interval cancer rate is significantly higher. So if you've got a 49% interval cancer rate, these are the cancers which are not detected by screening, compared to 25% if it's if you've got breast density A. So it's a significant issue. How have different countries managed this? Well, USOBI in Europe in 2022 published a paper recommending, according to level 1 evidence, and I'm so glad that you've led the way with the MRI scan, women with very dense breasts should be screened with MRI, probably about every 2 years at the very least, because this is where we've got a level 1 evidence, which is what we are screening women with high risk with. There's been a recent paper also published a couple of years ago as a meta-analysis looking at a pool studies of 22 studies, 132,000 women with dense breast and negative mammography, which concluded that the MRI was superior in detecting breast cancer compared to handheld ultrasound, automated ultrasound, or even digital tomosynthesis, which showed no significant difference compared to normal 2D digital mammography. Our current position, so the latest position looking at the current literature, tomosynthesis is helpful. It's better than nothing. It seems to be more helpful in very dense breast compared to the fatty breast. In most countries, people are still recommending supplemental ultrasound, for instance. And if you look at some of the data, it suggests that ultrasound with normal 2D adds an additional cancer detection rate of 3 per thousand in the dense breast. If you add ultrasound to DBT, which is digital breast ultrasound, the detection is roughly about the same, but probably slightly under, but the prospective trials are currently undergoing. Abbreviated MRI, not unsurprisingly, shows the greatest difference. For instance, in the dense trial, contrast mammography adds an additional 18 per thousand cancers detected, where a mammogram is already being reported as normal. And certainly, even compared against digital breast tomosynthesis, you have an up to 3 times breast cancer detection rate, compared to DBT. Contrast enhanced mammography, someone has done a very, very good lecture explaining how CAM is a new, even though it's not new technology, we're getting accruing evidence in using it, but it's not being tested yet in screening, which is where we come to the next one. So published this week in The Lancet is a multi-center trial performed in the UK in women aged 50 to 70. We identified women between age 50 to 70 who have breast density C or D, invited them to participate in the screening program in the randomized controlled trial, where they randomized into either abbreviated MRI, contrast enhanced mammography, and in 3 other centers, automated breast ultrasound. And the supplemental imaging is repeated at the 18-month interval. What did we find? Well, first of all, we found that the recall rate was higher in abbreviated MRI and contrast-enhanced mammography compared to automated breast ultrasound at 4%. We have roughly just under 10% for both contrast groups. However, we also found the cancer detection rate significantly higher, so roughly about 16 to 17 per thousand women's cancer detection for abbreviated MRI, and about equivalent for contrast-enhanced mammography, about 17. Even though the figures look high for contrast-enhanced mammography, it's not statistically significant. Compared to automated breast ultrasound, is running at about 4 per thousand. So you can see from the studies I've already shown you that automated breast ultrasound is roughly about the same as the published data for normal ultrasound, roughly between 3 to 4 per thousand women screened. Automated breast ultrasound did not pick up any DCIS, whereas both abbreviated MRI and contrast MRI detected additional DCIS not detected on normal 2D mammogram. That's not to say that we can throw away mammography. I want to show you this following bullet point. So even though the 3 times the cancer detection compared to normal mammograms in the contrast group, mammography also detected 5 cancers in the second round, which is not seen on either groups of the contrast mammography. And these are usually DCIS manifest as calcifications. So here's an example from our local Royal Free trial. Here we have a normal Barrett C patient with normal mammograms, and you can see that she was randomized into the contrast-enhanced mammography group, and there was a very obvious cancer that's been picked up on here, which is the invasive ductal carcinoma grade 2. So based on the evidence which we submitted from our BRAID style trial, the UK screening program has now announced this week that they will look at the latest evidence for breast density. And we will be hoping that the outcome is positive for the dense breast group, because they're promising to release the recommendation in August. However, this will be a significant challenge. I've already shown you that there is a very high number of women with breast density C and D, and there is going to we currently do not have any contrast enhanced mammography use in the screening program at all in the UK, and we know MRI is a very, very big ask. So I think this will be, my prediction is that we will roll it out with breast density D. we need to have a way of identifying the women, because at the moment we do not record the breast density within our National Breast Screening Program database, even though it's there for the high-risk group. So it's a bit of a challenge, but at least it's acknowledged that this trial shows a significant outcome in terms of cancer detection rate. And I have finished. Thank you very much for your attention.
That's great. Thank you for that. And we're going to talk a bit about screening in the discussion, because there's lots on social media about screening. So that's something that we'll address. Great talk, Will. And we'll do the last talk now with the, where's Gerald? He ran away or not? So Gerald is one of the consultants in Aberdeen. We worked together for a good 9 years, a very good friend. And he's going to talk, and he's leading AI person in breast imaging in the UK. So he's going to talk about AI in breast imaging, what are the new advantages and the updates. Thank you, Gerald.
No problems, Yazan, and thank you so much for your invitation to speak. And it's great to see so many people from all around the world. Good morning, good afternoon, and good evening to all. So, will we still be reading mammograms the standard way in the future? Will we be using AI? And what are the tools that we can have? I think I'll start first by explaining that when we read mammograms, it's random. I mean, if it's in a screening situation in the UK, it's 1,000 mammograms, and you might find 6 to 7 cancers, and they could be anywhere in that pile of those mammograms. At least in a symptomatic clinic, someone might feel a lump, and then you'll have a better chance with the mammogram. So if you could have some tool that says, hey, these mammograms have tumors in them at the top line, but the rest of them most likely are going to be normal. And that's the premise of AI. When the AI interrogates the mammogram images, it gives you back a probability score, something between 0 to 100. And if it says 80%, it's higher likeliness or higher probability that there's a cancer there. Some baseline facts first, though. These AI models that we're talking about, the companies like ScreenPoint, Transpara, Lunit that have AI models, these are CE marked, FDA marked models that are what we call the old computer vision, deep learning type of models that will give you the same result every time. Whereas large language models, the things you're hearing about ChatGPT and all the current AI you're hearing about, those are not the standard models that are CE marked. Those are probabilistic next word models. So the AI that says, oh, the quick brown fox. So you think of the next words, and they have got hallucinations in those type of things, the large language models, the ChatGPT style. So the ones I'm talking about today, and the ones that all the research is based on, are the dedicated computer vision deep learning models that give you the same answer every time. Those have CE marks, those have FDA marks, but the large language models, the ChatGPT ones that say you can, let's give an image, Gemini to Google, none of those have CE marks. So they're not safe for use in patients, and they even say themselves, this is not for medical use. The ones that we are talking about today do that. A lot of these AI models can only look at the same images that you have, the 4 images that Tripti spoke about earlier in the talk. They don't really look at priors, but the companies are always innovating, and they will start looking at priors. They don't learn on the fly, so they don't see the pictures and see the mistake and then learn again. They have to be released version by version. So it's like Windows versions or Apple versions. They only have the model that's fixed. And lots of companies doing lots of different things in the AI space. You're talking about companies that look at making the image better, some that look at QA to see if the picture is good, so your technicians and help your technicians get it right. There's others that look at the case scores, just standard ones that look at your mammograms and give you a score saying this is suspicious or this is not. There are some that measure density automatically. And there are others that are working in the field of ultrasound, MRI, and even CEM. So lots of different areas and all across the world as well. Does it really work? Is it all not real? And the National Screening Council looked at this in 2021, and in the UK, and they released an analysis of all the papers to that date. And the big papers basically said, a lot of that time in 2021, 3 or 4 years ago, it was all retrospective stuff. It was enriched studies. It was testing in artificial labs and on computers, without humans, just computer against the old results. And it basically said it was better, but no real life testing. It needed prospective real life studies. So do we have prospective studies? Well, the industry and all these academics took their spur on, and loads of trials reporting. Priam, which is a German trial, with a company called Vara reported this year 400,000 over women, and they had a cancer detection increase of 17.6%. I call this study the Everything Everywhere All at Once study because basically it gave the radiologist the option: you want to press AI, press the button, and then use the AI as well. And it tracked the ones who used the AI and the ones who didn't, and it showed this increase in that group. So that was an observational type of study. The big famous study is the one that comes from Christina Lang's group, the Masai trial, and that's a company called ScreenPoint. And what she did was 100,000 women, split it one half, which is just humans, the normal way, 2 human reading mammograms, and the other half was human and AI. And there, the human and AI arm picked up 29% more cancers. And if you have the usual way in the UK and Europe, which is 2 humans reading, now you have 1 human and 1 AI, straight away 44% decrease in workload because a lot of those mammograms that were normal are being eaten up and taken away by the AI. So already you can get efficiencies in turnaround time, and efficiencies in cancer detection. What's not to want? And that was a proper randomized control trial. ScreenTrustCAD was another very well-known company, especially in the Middle East and in Asia, called Lunit, and they had a control trial where they only saw the AI by the third reader. So if 2 humans disagree, the third human saw it, and even in that control situation, cancer detection increased by 4%. Our group in Aberdeen did Gemini, which was 10,000 to 11,000 women. Yazan was my surgeon at that point before he left me. So sad that he left Aberdeen. And already that was a safety net trial. So we used mammograms. 2 humans read it. And then the human said, this was fine, normal mammogram. And then we turned on the AI, and the AI said, look at these extra pictures first and check, because they had a higher suspicion score. And when we looked at those ones, we picked up more cancers, 10% more cancers. So the study type of ours was safety net. You got randomized control, observational. If you add those participant numbers, over 600 to 700,000 women already prospectively checked with AI, and you're getting results with cancer detection increase in all of them. Here's an example on a mammogram. On the left is one mammogram from 2019, and on the right is one from about 2023 period. And you might say maybe a bit of generalized increase in breast tissue, but you can't really see a big mass or anything very obvious. And that's a 3 centimeter lobular cancer in the yellow circle at the top of the picture. And then another one here shows the context that you need a human. You need a human with the AI. So I would always say it's not replacing us. It's definitely augmenting the human being, whether it's a surgeon or a radiologist or a GP. The AI is there to help us. And that's the tool that we need to use it for. Why? Because AI can't read the clinical notes. It doesn't have the information. So the bottom circle is a lesion with a clip. So that was a benign lesion that we biopsied. It's been pathology proven as benign. The middle circle, that's a lymph node. That just comes from experience. And also we did ultrasound to confirm that. But the top circle, that was TCIS. So that was a cancer. So again, humans and AI working together. We have information that AI doesn't. The AI looks at the pictures in a different way than we do. False positives is a factor in AIs at the moment, because this is that first, second generation of AIs in mammography. And for some of them, they tend to call back these lines that is circling there with these calcium. Those are vascular calcification, you're sort of hardening of the arteries that you see. So AI seems to have a predilection for that and for certain masses as well. So we need to work and be aware that even if an AI gives a 90% score, it's only right about 1 in 15 times. So that's sort of things that we need to have, the higher false positive rate versus the benefit of picking up more cancers as well. So real life use, has anyone switched it on properly in the screening scenario? Yes, our friends in Denmark, in the Copenhagen region, led by Ilse Weber, and that's before AI, 60,000 women. After AI, about 60,000 women as well. Recall rate went down, so we didn't call as many women back, so less false positives. Cancer detection rate went up from 7 in 1,000 to 8.2 in 1,000. So that's more than 10 to 15% increase. So pre-AI, post-AI, picking up more women, picking up better detection as well. So in the future, what's going to happen? Well, we've got lots of prospective studies coming, but the big one is the AI trial in the UK. So this is the EDIF trial that's being launched this year, and it's being led by Professor Fiona Gilbert in Cambridge and Professor Sean Taylor Phillips in Warwick, and I and a few of the people in the UK are co-investigators as well, to look at using multiple AIs, 4 to 5 different AIs across a platform like your PACS or your independent platform, where all the patient's pictures will go in. Each center will then have it analyzed. We're going to do 3 different arms: your control arm, the arm that has, like the Maasai trial, 1 human and 1 AI, and another arm where we get to see the AI opinions, where it says high risk or low risk, and then we can make a decision on how we want to interpret the picture and work with the AI. So interesting. Watch this space. Next 3 years, lots of interest in this trial. Dr. Will spoke very well earlier about all the different ways of scoring and doing prediction. And there's possibly a role for AI in combining cancer signs, the masking from density, and known risk as on the mammogram to say maybe we can subselect this group of patients for supplemental breast screening. And Dr. Strand's group in Karolinska in Sweden, and it's promising that other groups using mammograms as well to do AI scoring, and they're getting the same level of pickup as the BRAID trial from the mammograms alone, and independent of density, because it brings in other AI features on the mammogram. So very interesting sort of steps there in the future. So is AI only for people who can afford it? Is it only for the developed countries? I'm very well aware that AI is being looked at, and these webinars are also very popular across the whole world. And I think the answer is it's actually the way that we can use technology to help equalize things and marginalize this, and not to make it work better for everybody. I'll give you an example of a company that works with chest X-ray AIs in India, certain parts of India where there are no radiologists. So there's no one specially reading the X-rays that are being taken, and they are very active in TB screening. And most chest X-rays will be normal, but this AI is being helped to say, these look abnormal, they could have TB. So these chest X-ray AIs are just working places where you have no radiologists at all, and there's no capability. Similarly, AI that is, if you have a mammogram machine and you're able to have in the area, it may be that you are single-handed radiologist. You don't have a formal screening program with 2 radiologists like we do in the EU or the UK. Then again, AI is a tool. It's a tool that helps the doctor to see the images and say, okay, there might be something there might not be something there. When I say that it has a lot of false positives, it also is very good at negatives. When an AI says the image is negative with a score of 0 to 20, its miss rate is 1 in 3,000, whereas the average miss rate for a very well-trained doctor like myself is 0.5 to 1 per 1,000. So AI, when it says normal, actually scores better than I do. So there are different ways we can start using AI. One is also in ultrasound. So this company does AI in ultrasound. And again, I've seen trials in certain areas of Africa where they have portable ultrasound, and they're using this AI, ultrasound AI tools like this to say, they're coming with a lump, is it malignant or is it not? Simple as that. And you're able then to sort of have your trials from there to say if it's a cyst or not. In the UK, we want to reduce biopsies that are benign, because there's no indication to do a biopsy if the lesion is benign. So if it follows this criteria, we could actually apply AI and say, AI, along with the evidence that we see and the evidence we're gathering, says you don't need to do a biopsy in this patient. You don't need to cause trauma. You don't need to cause worry, and you can actually save resources. So this is one option for AI and ultrasound. And some countries do screening using AI, using ultrasound, not with mammography, because it's cheaper and it's more available. So again, this is an option that we can use in the world of ultrasound and breast. There are tools that are coming in for contrast and AI, as well as breast MRI and AI. So the area is rapidly developing, and there's lots of tools that are very interesting coming in. Some important things though, as I said before, post-market surveillance is coming in. It's very important. Most of the AI that works now is one AI company in one area with one machine or one group of machines. So what happens if you change that machine? Will the AI change its behavior? If you're using one AI that's trained on a certain population in one place, will it work in another population in another place? So as the initial excitement goes away, the hard questions are coming in, the what ifs, what can we do, and it's how we deal with that. We need a strategy for new software, new hardware. If we're buying it, will this AI work well in my population? Will it pick up the high-grade cancers that I want it to pick up? Will it work in very dense breast tissue or older or younger women? There's a talk of how we're going to work with humans. Will we start having something called automation bias, where we just say whatever the AI says, I'm following it, because that's not what we are here. We are doctors or clinicians, and we have to trust ourselves and work with our own strong basic science first before we turn on the AI. And there are ethical concerns. If an AI is trained on a certain population, will it discriminate against another population in unintended ways that we don't even know about yet? So that's why the research is heading that way. That's why we need these prospective trials. This is an example of work from the University of Aberdeen, where we looked at 4 years of mammograms over 4 different machines. And there was a software change in these machines. So if you look at the 4 lines there, the different colors, and then you see that line going woof up there after the word that says event, that was a software change that made the image a bit sharper. So the human performance didn't change, but the AI started calling back 40%. So every second woman is basically being called back. So there was a change in the software behavior of the AI when we made the picture different. So these are things that you need very good surveillance and you need your alerts, because if the AI starts changing, are you going to turn it off? What are you going to do there? You need to have your systems to monitor it first to even notice the difference. So a little bit about ChatGPT to end this. And yes, large language models are coming in. These are moving into the visual world as well. There is early work, for instance, in this X-ray here. And we fed this into a medical AI visual model, and it was giving reports that come out and automatically generated there. And you're talking, well, it's quite good. It had transverse fracture, distal radius, and stylo process fracture. So this is still coming, but we're still having that sort of hallucination issues and interpretation issues coming true. But I could see more work on this in the next couple of years in the mammography and X-ray and chest X-ray field to come. But maybe that will be another lecture with Mr. Masanat. And we can use AI in the way, the ChatGPT tools, to learn things faster, to sort of bring more information to ourselves for evidence synthesis, as a mentor to talk to give yourself tests and quizzes. I have a role in a medical school where I teach the medical students about AI. And these are some of the sort of ways we say you can use it in a different way. But number one, don't put any patient details into a public facing a large language model like a ChatGPT, because then the patient's details are shared in that way. So something about privacy to be very careful about. And AI affects all areas. So it's not just in imaging where it started from, but it can go to areas of pathology, your proteins, your proteomics, your genetics, types of treatments, what's the best chemotherapy, prediction and prognosis, as I spoke about earlier, even simple things as automation, your ambient AI for your voice dictation, your planning. Future AI might say, okay, you can open a clinic here, but then the road doesn't have any buses or transport to that area. So it's a really interesting field of what we can do in future here. So I think I'm going to give some time for Q&A because we're almost at the end of this. And just big thanks to everybody here and to my fellow members of the British Society of Breast Radiology Committee, Simon and Tripti, and Will by honorary extension as well in joining this call. Thank you very much.
That's a great talk, up to the point, Gerald. And we'll just do some housekeeping and then do the questions. You're having lots of hearts and claps from the online. Now, I will send you all the CPD points and the certificates in the next week or so. Don't need to send me emails asking for that. It will come automatically. We'll go through a few things online, few of the questions on the Q&A section, but we might not be able to go through everything, unfortunately. We'll try to go through as much as we can. Remember, the majority of us are surgeons online, but it's great that we have other specialties because we need to learn more about imaging. The next webinar is about radiotherapy. It's also another important specialty for us. The one after that is about genetics and hereditary breast cancer, and the one after that is about cosmetics. I always say, you're as good as your radiologist in theater, because if your radiologist told you it's a 10 millimeter tumor and you end up doing a wide local excision for a 10 millimeter tumor and find it's 25 or 40, you will have involved margins and you'll be end up in trouble. So they are our eyes. They see where the problem is, and then they give us the diagnosis, and they guide us where to go into theater. But we as surgeons, we need to know the basics of radiology. We need to be able to have a look at a mammogram and see roughly where the problem is, especially when you're doing surgery, especially in doing the specimen X-ray. Many radiologists do their own, many surgeons do their own ultrasound scan, not only for diagnostics, mainly for theater and sometimes for procedures. And we have the lovely Jem Yilmaz with us. Jem is one of the surgeons in Istanbul, and he does lots of his own scans. Also, he has some radiology teams that cover the clinics and things like that. But he'll assess the patient in clinic. He does his scans. Also, he does radiofrequency ablation on tumors, and he's been presenting lots of studies. One of them was presented, I think, last month in the American Society of Breast Radiology, and Jem was one of the keynote speakers there. So it's great to have him online. Jem, as a surgeon, how important is for us as surgeons to know as much as we can about imaging and about radiology?
Well, actually, I would love to divide our journey, our job journey of our job before Cobalt trial and after Cobalt trial, because in 2013 a lot of things changed in our lives. So that after 2013 for the Cobalt trial, our life, I mean our breast surgery practice is mostly like data management, because we are receiving the data from the radiology unit, and we are receiving the data from the pathology unit and from the history of the patient, so that we have to collect all of them and to organize a personalized treatment plan for the patient. So in order to understand the reports of the radiologist, now we all must have the ability to understand the PACS softwares. I mean the picture archiving systems. I think most of the audience here have their, in their hospitals, the PACS software. So that PACS literacy matters. So as a breast surgeon, I think I have sent a screenshot in the chat module that from the AGO guideline, it says breast surgery is only a substep out of multiple steps in breast cancer treatment. So all breast surgeons must have the ability to understand radiology, pathology, and oncology, so that we must focus on, PACS literacy in the 21st century. So ultrasound is the first step for that. Why? Because ultrasound is a user-dependent technology. For example, it is the report from the eyes of the radiologist. You receive a static report, and you receive the static images of the patient, of the breast, so that we need to understand where the tumor is. We need to understand the neighborhood of the tumor itself, and also we must have the ability to interpret the mammogram and the MRI. So data management in 21st century is crucial for all the breast surgeons, as it is mentioned in the AGO guidelines in the first page of for the breast surgeons guidelines.
So Jem refers lots to AGO guidelines because he worked in Germany, and he was trained in Germany by Mehdi Rizai and by many people in Germany. And that's why in Germany, lots of people are gynecologists and they do their own ultrasound scans. Also, to be able to plan your surgery, you need to look at the mammogram, and you need to be able to have that 3D image in your head to be able to do, can I conserve this breast or not? And if you don't have that, you end up doing more and more mastectomies. Now, we had a lovely talk from Tripti. I don't know if she's still online because I cannot see her. And look, it was a lovely journey between the different uses for imaging. Now, one thing that we keep on arguing about is chemotherapy. You always image before chemotherapy, and some people image after chemotherapy. And I've worked in different places with different MDTs. In Aberdeen, we were imaging before, midway through, and after. And then at the end, we said, we really don't need that midway through. It's not changing management. So I don't know, in Essex now, because of logistics, if we do it after, we might struggle to be able to operate on the patient. So we do it before the last cycle of chemotherapy. And sometimes that does not give you the whole picture. Because some of the excellent responders, it makes a difference that 1 or 2 last cycles. Any comments on that, Tripti, on chemo imaging?
So a baseline is something that is required. And one thing that I would say is the same investigation that is used as a baseline should be used as follow-up imaging as well. That's one. If the mid-cycle MR, the oncologists do prefer a mid-cycle MR because it allows them to check whether the cancer has responded, although they are going to change treatment midway, but they do like to know whether it has responded. So once it has responded, if it's shown a complete response, then an end of treatment cycle MR may not be required. That is something that we have started to follow.
Any changes, Gerald, since I left you 1.5 years ago? And how you do things in Aberdeen?
Well, we're starting a new trial called CSER, which is comparing CEM and MRI at the start, the mid, and the end point. So actually, we're going to have more information soon in future about use of contrast imaging for that. But we do currently just do standard mammo and ultrasound at the start, middle, and end currently. But we're looking to have that new start there with the MRI/CEM.
Simon, do you still do the mid-cycle one or not?
No, never. And the only time would be if the oncologists were concerned about disease progression or non-response. Obviously, as we do more neoadjuvant chemotherapy, the cancers are getting smaller because we don't have the small cancers that are based on their receptor status, not necessarily disease burden. So even those impalpable ones, we tend to just do one at the end. I didn't have a chance to mention Caesar just in the short time space available, but yeah, that's going to be a good study within the UK to look at whether contrast enhanced mammography is non-inferior to MRI for that purpose as well. The other thing to add, Yazan, as well, which is not, it's maybe somewhere in the future, is the advantage of having your imaging at the end of your neoadjuvant chemotherapy. It may not impact things too much because you'll still be excising the tumor bed, I guess, anyway. And if you've got an approximation as to how big that tumor burden is likely to be, then it's probably helpful. But it's one possibility that we, in the future, may be moving towards sampling the tumor bed preoperatively and deciding whether our imaging correlates with pathology based on an extensive biopsy, for example, a vacuum assisted biopsy. And it may be the future that we don't end up doing surgery at all. Maybe controversial, but that's something we need to think about.
We had Henry Curer talking about his paper on the webinar about 6 months or a year ago.
Oh, really?
Surgery and excellent responders. So always a great concept to think about. Jem, I think things different in Istanbul. Tell me.
Well, during the primary systemic treatment, the neoadjuvant treatment, I think ultrasound is the gold standard to understand the downstaging of the tumor. When you have an axillary positive, axillary involved breast cancer, axilla, I think, ultrasound is the perfect solution for the axilla. So that during the treatment, as you know, in Germany, the gynec-oncologists give their own treatments also. There are not too much hemato-oncologists in Germany, so that in our clinics, we were giving our own primary systemic treatments to our patients, so that during the follow-up period of the primary systemic treatment, we are using, and still in Istanbul, I'm using ultrasound during the treatment, because ultrasound in the axilla especially gives us a lot of information for the downstaging. And according to the rules of the radiomics, when you have a microcalcified breast tumor, HER2 positive breast tumor, and in the solid state, you can see the shrinkage of the tumor when you screen the patient at the beginning, and 8 weeks or 12 weeks after the first the initial treatment, and at the end. But what we do before the neoadjuvant treatment, we've performed breast MRI, mammogram, and ultrasound, and also the ultrasound from the radiologist and from the surgeon's perspective also, because I am going to be the one who is going to operate the patient, so that I have to know all the connections, all the neighborhood of the tumor before the treatment and after the treatment. So ultrasound in the hands of the surgeon is the gold standard, as it was emphasized by Susan Klimberg in 2001. That is, ultrasound in the hands of the surgeon is the gold standard. I don't know what my British, colleagues are thinking, but
What you have is you have a great setting, Jim, and we don't have that. He has the ultrasound scan in his room, in his clinic room. So he'll see the patient. After examining the patient, he'll just pick the probe and put it on the breast. So sometimes what I do, and Gerald knows that when I was in Aberdeen, and I do it now in London, for planning treatment, when they do the last scan, and if they do put a mag seed or put a savvy scout or they localize the patient for me, I say to them in the clinic, I want to be there when they do the scan. I want to see where the probe is. I want to see where the tumor is, because I plan my surgery that way. So it will be handy to have that ultrasound scan in clinic, but that's something that is not available for everyone. I want to touch on the lymph glands because, Tripti, you mentioned cortical thickness of lymph gland, 2.5 mils. But I've worked in MBTs that they talk about 2 mils. I worked in MPTs that talk about 3 mils. I work in places that go up to 4 mils. And that's sometimes a completely different surgery that the patient ends up having. Any comments on that, Tripti?
There is a big audit that is being done, the Avoid audit run by the BSBR, and we will have slightly better guidance as to what is the cutoff for the cortex. Certainly, it's the sensitivity specificity debate when it comes to increasing cortical thickness. Also, with reduced treatment of the axilla, I guess the aim is not to biopsy everything. And also, there is a bit of discretion that I would use, and a lot of my colleagues use, I'm sure, with respect to lobular cancers, where if there is a lymph node which may have a cortical thickness of less than 2.5 millimeters, for example, in our practice, but we think it just looks a little bit odd, I would go ahead and biopsy it. So, yeah.
And can I ask one final question, because nearly finishing, it's nearly 6 o'clock. PET CT scan and lobular cancer, we always argue about that. Now, in the breast, it might not be great because the cells are small. When they go to the lymph glands, it will not swell up that big. There will still be small lymph glands, so it might not highlight the problem in the breast. But is it any good for staging also? I always argue it's not that great for staging. It can pick things if it's big and obvious, but it still can miss things. And there's no extra benefit from a PET, just do a normal CT scan. Any comments from all three radiologists online? Let's start with Gerald.
I'm actually going to refer to Tripti because she will refer to a webinar on the British Society of Breast Radiology where we have Dr. Shihil Bhuva speaking on this very topic. Tripti, would you like to speak about that?
Tell me, Tripti.
Yes, so on the 27th of March, we had this fantastic webinar by Dr. Shahil Bhuva, who spoke about PET CT and where it scores over CT, and sometimes these are used as complementary because it picks up little lesions on the bones, etc. And certainly in things like inflammatory cancer and lobular cancers, it can be used. And there was another webinar actually by Dr. Ian Lyburn and Dr. Thomas Jones, which was done more recently on the 15th of May. I would really recommend that these two webinars are watched for a more detailed view on this. There's a lot of important.
Those webinars are free for all. The link has been sent on the chat function by Gerald, so please have a look at that. Now, any final comments, because we needed to close now? Any final comments from any of the speakers and the panelists?
Very quickly, Yazan, the 5th edition of the Symptomatic and Screening Breast Guidelines is being written by the committee, and we should have it out sometime this year, and it will be issued by the Royal College of Radiologists as we are part of the special interest group. And we'll let you know so you can publicize that as well.
That's great. Any other comments? I just need to thank you all. You've been all great. Thank you for giving up your Saturday afternoon. Tripti, Gerald, Simon, Will, and Jem. And also we have the great interpreters. Mikael, it's great to have you. Akram, thank you again for coming, for joining us again. Katarina, thank you for joining us again. It's also, he's part of the deal always. Ricardo Pardo has been with us for a good few years doing that. Now, for people, remember next webinar is the 28th of June, and we have great speakers about radiotherapy, and I think it's a great webinar also. We have one in the mid-July that I haven't started. I've started talking to speakers. It will be mainly about genetics, BRCAs, and hereditary breast cancer and surgery. So that will be another webinar with lots of debate, I think. Then we have one on cosmetic breast surgery in August with Mustafa Hamdi, and he'll get lots of the aesthetic surgeons from Europe to give a talk on that. So we'll be sharing all that on our newsletters. Please also join if you're not already on one of the WhatsApp groups. I've shared the link for the WhatsApp group few times. This is another link. I have 4 or 5 different WhatsApp groups. Just join that because each of them have nearly 1,000 people. Now, for people in the States and South America, have a lovely day. People in Europe, and have a lovely evening. People in the Middle East and in the Far East,